Good afternoon, good evening, everyone, wherever you're joining us from today. We want to welcome you to the Nurse Policy Entrepreneur Cafe. We believe that nurses are well positioned to incorporate health in all policies because we're the first witnesses to all of the determinants of health, and we keenly understand that health system strengthening expands beyond traditional direct care roles. Nurses work in multiple spheres of influence to shape health and social policy that addresses problems in healthcare, including in the workspace, in government, associations, and in civil society at large. The origin of the word entrepreneur comes from the French language that denotes a person who undertakes a project. So this doesn't necessarily mean business entrepreneurship. This concept is not unfamiliar to nursing professionals, and societal changes have been initiated by individuals who have observed a problem and figured out how to disrupt the status quo and the equilibrium to improve something. And policy does not always mean politics, and deriving effective change does not always mean running for office to do so. A policy is just a set of ideas or a plan of what to do in a particular situation. The Future of Nursing report has a multidisciplinary call to action for nurses to assume leadership positions and serve as full partners in healthcare reform, from practice to policy, including in decision-making for national policy. And nurses must prepare to engage regardless of our practice settings. Nurses, as the largest constituent profession, have maintained our status as the most trusted profession for decades, yet we're rarely engaged in the process of healthcare policy making. The concept of nurse policy entrepreneurs, while it's been practiced for centuries, is often overlooked, and this gap is not only from our invitation, but also our struggle to identify as thought leaders in this arena. So, becoming engaged as a thought leader and policy influencer is an element of our professional identity, with the beauty of diversity in our individual perspectives, personalities, and leadership roles. If we leave it to other disciplines to determine healthcare policy, whether they are healthcare providers or not, reform will be marginalized. We must become known as more than just the trusted profession, but also as the most influential when it comes to policy, because we have the highest touch points in healthcare. So, how do we address these issues? As the complexity of policy increases, a higher degree of expertise and skill sets become more important. It becomes harder for individuals to influence policy. But if we foster dialogue, inclusivity, innovative thinking, we can better understand how to engage. Our methods here at the NPE Cafe are based on theory to address the gaps between ideation and action. We promote diverse insights for meaningful evolution. We use Parsi's human becoming community model to describe how the concepts of co-creation lead to community building and evolution. And the World Cafe method is the gold standard that establishes a psychologically safe environment for collaborative innovation and shared learning. There are three change concepts that might seem paradoxical at first, but they really complement discussions and shared learning. This includes moving and initiating. Think of how we shift between somewhat chaotic discarding and creating of new ideas and meaning as a result of these conversations with others. And then we have anchoring and shifting. So recognizing that when an idea improves your previous thoughts and shifting them after this contemplation, or anchoring further down in your previous thoughts and making them stronger as a result. And another one is pondering and shaping, so dialoguing and then meaningfully listening to complete thoughts of others. This is the basis of our cafe that we host once monthly. We have no affiliations, no paid membership, no eligibility criteria that prevents getting engaged, no barriers, and no borders, because nurses need an organized process to meet, network, and discuss approaching these issues, not debating our stances on them. In holding this space, we create structural empowerment for nurses to become effective policy makers and implementers, while simultaneously exploring how to create a system for true deep democracy at all levels to improve our communities. It breaks down imposter syndrome because by facilitating this evolution and guiding nurses through group mentorship to resources and inviting them to be active, you embody what you believe to advocate in new ways. We are open to all nurses and students at all levels and in all settings across the world. Now, you can start with your own preparation. You can clarify your why, your reason, your purpose, how you got into nursing in the first place, and continue to develop an expertise beyond your clinical expertise within hospital walls. Create a personal professional development plan. Find organizations that share your why, share your values, and join them, and be able to engage with them, developing your social and political network, and by just practicing reading, writing, and speaking as much as possible about this to develop your expertise and become that subject matter expert. Then you can take a deep dive into our skill sets. We've organized a living and evolving list of essential skill sets that one might need to develop all or part of their professional expertise and their identity as an NPE across the career continuum, which can change. Your needs can change as you grow. And you might organize these a little bit differently, or you might share something that you think we're missing in them. And now we do have some netiquette that we follow. It's very simple because we believe in open access to these resources. We do record these sessions so that our community members across the globe who cannot always join synchronously each month can access this information. When we have a speaker, we get their consent to share this and have first rights to edits before we have our Zoom session. To maintain our psychologically safe space, we do not share the discussion that follows. There might be occasionally really robust Q&A afterwards that really adds to the month session and the discussion and conversation, but we carefully either edit this and include it without sharing the community member's name or face or voice, or if that's not possible, we ask for consent to do so before posting it on our website or YouTube. If you want to completely make sure that you avoid any type of this inclusion, feel free. Leave your camera off, stay on mute, and you can engage with us in the chat, which we never share. So here's some of the resources that we regularly share our material on. The online process includes a one-on-one navigation guidance for newcomers to our cafe and community. We onboard them to theoretical foundations, as well as the resources that we've developed so far, and the process for our monthly cafes. We have resources that are collectively aggregated in a multimodal repository for adult learning and various styles of learning. We have a modest website. It does serve as our centralized source for these efforts. These resources are infographics, we have roadmaps, educational content, links to springboard you to other resources that already exist out there that we don't need to recreate. We just kind of curate them for you. And our monthly Zoom Cafe sessions have evolved to highlight a speaker organized with this skill set so that we focus on every component of them as much as possible in a know one, see one, do one modeling. And we share this experience from nurses to nurses, and we share our dialogue about it. The implications are just that, at the very least, you as a nurse policy entrepreneur walk away from each cafe with a little bit more understanding about steps you can take to make an impact. We seek to empower nurses as influential advocates and full partners in healthcare reform, translating advocacy to policy. After dialoguing in our open door, judgment-free space, using our resources, and diving deeper into your why, we as nurses can build upon our practice of advocacy out in the world and in broader engagement. So let's get started. And I would like to pass this off to Michael. Would you like to introduce our speakers today?
Yes. Also, I wondered, is there a way that we post our Substack, a link to our Substack newsletter?
Oh, yes, I can do that too. Mm-hmm.
Is there, I was looking at the website and I wasn't sure I could find out how to access that. So that might be something else, because one of the things that we try and do is keep constant communication with folks who are interested. You subscribe to it, so it's at your will. And we use Substack as a way to distribute that. I'm really excited about today. This is something, policy analysis may sound complicated. It may sound pedantic and heavy, but it's really a very important part of what we do. And I wanted to share real quick, go back to this photo. So if you look at the essentials, these are the different aspects, the qualities of somebody who is going to be effective at policy, whether it's talking with your city council, or if it's a community board of directors that you're on, or whether you're talking at a governmental agency like a legislative body. regardless of where that is, you need certain skill sets to be effective. You can't just walk in with passion and say, I have a great idea. You need some skills. And so we've set aside these elements. We call them elements and essentials. And if you look through these on policy making, policy analysis is one of those skills. It is a skill. It's something that you can learn. How do you look at a policy? And there are different steps to that, and there's a lot of different approaches to that. I found that our speakers, our presenters today, Javeria and Arsham, they presented at a conference at the annual Cabrera Lab conference, which is a systems think tank project out of Cornell University. And they presented their approach to looking at policy. So there's two things to think about today as you do this. And if it's effective, then number one, you're going to think differently about this idea of policy analysis. Number two, you're going to be interested in learning more, so you're going to want to ask some more questions. Number three, you're going to be inspired to do something, whether it's to learn or it's to go out and apply some of these things. So today should be give you some tools to apply some of that knowledge and information that they're going to share. And you can see that there's a lot going on in this picture. So our cafe is part of that. It's one element. It's to share with you other experiences so that you can see what other people have done and apply it to your own hot button, whatever it is that you're working on. So you can share those experiences, translate in your mind how you can utilize those to be effective. Number two, our website is a place where we have resources. We're trying to connect with one another, so we have networking, but also we have tip sheets on how to go about each of these elements and essentials. How do you develop an elevator speech? So we're doing two things with our community. One is we're bringing information and knowledge and resources, but the other thing is we would like to know how we can be more effective at that. So I've been looking at artificial intelligence on changing the way that we learn. Right now, it's more of a vending machine approach to where you think about what you might need, or you go to school and they tell you what you need, and you go to that, and it's a retrieval system. You retrieve things. Well, what if artificial intelligence and chatbots were to take information that you took in request and design some kind of a curriculum unique and special to you in a form that would be unique and special to you, so it would be applicable. So we're thinking about how to redesign the idea and the concept of education through our website. So as you think about today's presentation, think about how we might be able to translate AI and chatbot technology into our website in order to help folks learn and understand. So that's the backdrop as you go through today. Think about what we're talking about, and also think about how we can deliver some of this information, maybe even a little bit better. So I'd love to introduce now Javeria, Kamran, and Arsham Bari. They're great presenters. They've got a great topic today. So I hope you have paper. I have some basil here. That's my my aroma of choice today to kind of stimulate the way my brain is working. I take this very seriously. I try and take as much as I can, and that seems to help me. So I'd like to introduce you now, and I'm going to take my thing off and give the floor to our presenters. Okay, take it away.
So my name is Arsham. I'm going to allow Javeria to start. Javeria, is the screen set for you?
Yeah, that's it. Thanks so much. So, hi everyone. Thanks so much for joining us today. It's super exciting to be here. We've been prepping this presentation, and we're kind of also excited to learn from you because we're policy students, and we're really excited to kind of talk about systems thinking and see how we can translate that into a nurse context. So yeah, I'm Javeria Kamran. I'm a recent Fulbright Scholar and graduate from Cornell University, where I specialized in environmental policy and city and regional planning, where I also earned a certificate in systems thinking, modeling, and leadership. And I'm super interested in how systems thinking can help uncover why policies succeed or fail, and how more coherent and inclusive systems can be built by using systems thinking. I'm joined here with my dear friend and colleague, Arsham Bari. Arsham, you want to introduce yourself?
Yes. Hello, everyone. Thank you so much for allowing us to share this opportunity and share this space. As Javeria said, we are newly graduates. Me and Javeria were together at Cornell. We were both Fulbrighters, and we are both from Pakistan as well. And that is where I am currently based. Um, so me and Javeria, we did the certification in systems thinking together, and we worked on the final project as well. So other than that, I am a public policy professional, and my work is designed around evidence-based, equity programs and community-centered, implementation of different policies. My work has mostly been with vulnerable and marginalized communities, including women, youth, religious minorities, and other gender minorities. And basically, I have always used data and evidence-based research to reimagine policy implementation, or how we can decrease the gap between the policy making and the policy implementation. And I think one of the additions to that work has now been the introduction of the systems thinking, and how we can actually use that to inform better policies, not just like during the foundation of it, like when we're setting the foundation, but also when we're trying to implement it in real time. Yeah.
Yeah, so that brings us to our topic for today. So we're gonna be talking about why policies that appear sound on paper frequently fail to achieve their intended outcomes in practice. And this is something that we've all seen and we've all experienced, and we all live the repercussions of as well. So just to kind of introduce systems thinking and systems thinking in policy. A lot of times, this disconnect between how they were described or intended on paper and how the outcomes were in practice isn't typically due to lack of effort, resources, or good intentions. Rather, it often stems from a fundamental mismatch, which is how we organize our thinking about the problems that we're trying to solve and the actual complexity of the systems those policies are meant to influence. So, throughout our presentation today, we introduced you to systems thinking in general, and also Dr. Laura and Derek Cabrera's, DSRP thinking framework that kind of addresses this mismatch directly. So our goal by the end of the session would basically be that you have a practical cognitive framework that helps reveal structural patterns in the policy challenges you encounter in your nursing practice and leadership. Shim, could you go to the agenda? Yeah, so this is our agenda for today. Our agenda covers 4 connected areas. We'll talk about what system thinking actually means. It's not an abstract concept. We're gonna, approach it a bit more practically to understand all the ways we can use systems thinking to understand complexity. We'll ground this in definitions from researchers who we've studied, and second, we're going to go deep into the DSRP framework, again by Dr. Laura and Dr. Derek, and kind of see the 4 fundamental patterns that, according to their research, structure all complex thinking. Third, we'll kind of practice applying these patterns as well through the session. And we'll try to directly kind of make it relevant to healthcare policy and nursing practice. Because we're not healthcare professionals, it would be, feel free to kind of help us apply that to a nursing context. So we're looking forward to your input on that. And then finally, we'll examine how the DSRP framework applies to the actual policy challenges you face. And we'll look at why certain policies succeed or fail, and how we can kind of approach policy design more systematically, and how that might lead to a different or more effective solution. So we'll kind of use this session to move between concept and practice. So we'll try to keep it interactive. So let me begin with Dr. Jennifer's definition of what systems thinking is. So systems thinking is a holistic approach to analysis that focuses on the way different parts of a system interact and how they influence one another within a whole. So to understand where systems thinking comes from and where the Cabrera's work fits, it's also good to kind of look at the evolution through what scholars call waves of development within systems thinking. So just very briefly, the first wave emerged in the 1930s and 40s, which had two parallel movements. Ludwig's general systems theory in 1937 argued that certain principles like feedback loops, emergence, and self-organization appear across different types of systems, whether biological, social, or mechanical. Around the same time, Norbert developed cybernetics, which focused on communication, control, and feedback in systems. And these both kind of represented a fundamental shift from reductionism, breaking things into smaller pieces, towards understanding how the pieces interact with each other and understanding wholes and their emergent properties. The second wave started in the 1970s, and it recognized that all problems are technical, that not all problems are technical. So Peter and others developed soft system approaches that emphasized how different stakeholders construct reality differently. And this was particularly important for, human-centered and messy problems where there's no single agreed upon definition of what the problem even is and what our understanding of the problem is. And the third wave in the 1990s acknowledged the plurality of methods and grappled with questions of power, ethics, and which approaches work best for which problems. This also saw Peter Seng's 1990 book called The Fifth Discipline, which brought systems thinking into mainstream business and organizational contexts, making these ideas accessible beyond academic circles. So now what the Cabreras call the fourth wave focuses on cognition itself. So rather than adding more methods or tools to an already very overcrowded field, the research that we will be discussing in the framework that we will be discussing today asks the fundamental question that what are the universal cognitive patterns that make system thinking possible? So their framework, which is the DSRP framework, it stands for distinctions, systems, relationships, and perspectives, has emerged from studying the deep structure of thinking itself. What makes their contribution distinctive is the empirical evidence showing that these aren't just useful frameworks they invented, but they're actually fundamental patterns of how cognition organizes information. The research suggests that these patterns mirror structures found in nature because thinking itself is a natural phenomenon. So for those of you working in healthcare policy, this kind of evolution matters. Cabrera's work suggests that underlying all these methods are four basic cognitive moves that we can learn to apply consciously and deliberately, regardless of which specific tool we're using. And that's what we're going to explore in depth today. Actually, next slide. So systems thinking can be understood as the intersection of two things: systems, the complex adaptive systems that exist in reality, and thinking, the mental models we construct in our heads to understand that reality. So let me clarify what a mental model is. A mental model is basically how we organize information in our heads to make it meaningful. So every time you understand something, whether why readmissions are occurring, or why staffing affects quality, or why a policy has failed or succeeded, you're constructing a mental model. These are cognitive structures basically we use, and build to describe, explain, and predict the world. Now, mental models are essentially information and how we organize that information together. So a mental model will be information and how we've organized that information that would come together to, be your mental model. So most people assume that policy failures come from lacking information. If we only had more data, it would be better. But however, the problem is also organizational. It's not only that we don't have enough information, but it's also about how we're organizing the information that we do have. And if the way that we're organizing the information about an issue are we doing it in a way that is matching the actual structure of the system we're trying to influence, or is there a big disconnect there? And that is exactly where the DSRP framework becomes valuable, because the DSRP framework identifies 4 universal patterns for organizing information: distinctions, systems, relationships, and perspectives. These patterns appear to be structural features of both cognition and nature. They're not arbitrary categories, but they're fundamental ways that information is organized in both our minds and in real world systems. So when we use these 4 patterns to organize information, we're kind of increasing the structural alignment, which is the degree to which our mental models and our understanding of the world actually is close to the structure of reality. So because of that, if we're organizing the information in our head in a way that is closer to the complexity that is present around us in reality, we're kind of becoming close to discovering the hidden architecture of the complicated systems around us. We also know that, for example, in healthcare policy, if we apply like linear reductionist thinking to genuinely complex problems, we're typically addressing just visible systems while we're missing underlying structural causes. So when a mental model doesn't match the system's actual structure, our interventions just produce unintended consequences and don't often solve the problem. Yeah, next slide. So let's finally talk about the 4 patterns that I've been describing for very long. So they're called distinctions. I'm kind of repeating it because even when we were getting our systems thinking training, we often had to repeat it because it's really something that you have to drill into your head. So apologies, it might be slightly annoying, but these are really the words to remember so we can kind of practice it in our real life, which is the most helpful way to learn this. So D stands for distinctions. Any idea or thing can be distinguished from others. Every distinction consists of basically an identity. So what something is and what something is not. Arsham will make you practice these later in an exercise as well and go deeper, but just kind of try to listen through to understand because it's a little bit complicated. So D is distinctions. Then S stands for systems. So any idea or thing around us can be broken into parts or understood as a part of a larger whole. So this pattern allows us to examine things at different scales. So we're able to zoom in to see the minor components, and then we're able to zoom out to really see the broader context. The next pattern is R, which stands for relationships. Any idea or thing is connected to other ideas or things. We know this from our lived experience as well, where we often need to be more intentional about it. So relationships consist of actions and reactions and how things influence, depend upon, or affect one another. And P, which stands for perspectives, is that any idea or thing can be viewed from different perspectives. So each perspective has a point, the position from which we're viewing, and a view, what we see from that position. So if, for example, actually, Arsham will go through the moves and explain those later. So what is it that makes these patterns significant in, for us? These patterns basically underlie all cognition and are universal to the process of structuring information, which is why training our thinking into these patterns is very important. It's also significant to note that these patterns don't work in isolation. Each pattern implies the existence of the other three patterns. So, for example, if a thing can be distinguished from another thing, it is part of a system, it has relationships, and it can be viewed from different perspectives. So each pattern implies the existence of the other three patterns. Whether you make a distinction, you're simultaneously seeing it from a perspective, potentially identifying its parts and wholes, and recognizing its relationships to other things. They're not sequential steps, but they're often like interdependent elements that work simultaneously. So cognitively, we're almost always doing this. This is described within the framework as co-implication. So, in order to go from thinking to systems thinking, which is metacognition, awareness of one's thinking and mental models, it's kind of necessary to, to acknowledge these patterns and use these patterns intentionally. So, making this explicit increases metacognition and allows one to make structural predictions that lead to new knowledge, innovation, invention, insights, and discovery. For nurse policy entrepreneurs is obviously particularly valuable because you all work in genuinely complex environments where linear cause and effect thinking often fails. Having explicit frameworks for organizing complexity can give us all the tools to see patterns others miss and to articulate structural problems a bit better. I'm going to pass the mic on to Arsham, who will make you practice all the patterns and understand them a little bit better.
Okay, so now comes the interesting part. Also a little complicated, I understand, because I know we have gone through it for a year, and it takes a little while to understand what we're exactly talking about. But let's start by talking about distinctions. So I would also just like to add that we are talking about all of this in the policy context, but it is also important to understand that these moves or these rules are something that you can apply in everyday as well. And that is actually where you can build the practice. So we're going to be talking, about these different rules or moves that happens with each of the DSRP. And if you just like try practicing them every day, while you're on a walk, or, while you're making your tea or anything, it kind of like really sits in your head and you actually start doing that very automatically. And I have a very weird example of it, but because I was thinking a lot about DSRP because of this presentation, I was listening to this song. Me and my cousin were vibing to a song yesterday, and very automatically there was this like one part where the guy is singing the song, and then the girl is singing a song, and it's supposed to be a love song. And I just like, it just clicked in my mind that the girl talks about her love by saying that you're everything that I ever dreamed of, you are my leader, whatever you say, that's like everything that I've ever wanted, and now I have a fulfilled life. And I was like, okay, that's a little, I don't know, patriarchal or misogynistic. Does the guy say that at all in the song at all. And no, he doesn't say anything like that. He just says that, I really like you. I really, you are everything that I ever wanted. But that's it. There was no talk about leadership. There was no talk about, my life is fulfilled and everything. So it's like a very weird example, but something that I actually use systems thinking, where I was like, making distinctions, or, finding systems of, what is or what is not, or, how we are actually, looking at things. So it was just a different perspective that I thought that I would share this weird example with you guys. So let's start with what distinctions, actually is. So when we name or we give a definition to something, what we're doing is that we are drawing a very conceptual boundary around it. So every distinction would have two sides. One is, for example, X or not X. So what is and what is not, and we call that identity and the other. And this arrow that is, the double-sided arrow between all of these, you would be seeing further as well. What this means is that both of them are existing together. So one cannot exist without the other. And this would be true for all the different moves that we would be talking about. So, for example, when we say that, for example, apple is a fruit and it is also sweet and edible, that's the visible part of, what we're looking at. But what we usually do not say is that apple is not a vegetable, or apple is not sour, or apple is not unedible. So sometimes we look at the identity part of things, which is that apple is a fruit, but we forget to look at the other part of the thing, which is that, it's not a vegetable, or it's not unedible, or it's not sour. So it is very important that we also, look at both of these things. And when we talk about it in the healthcare, policy context, the clarity of distinctions become critical for implementation. So, for example, questions like, what is considered safe staffing, or what is not considered or does not constitute as, safe staffing, or what is patient centered care, what are the things that does not meet that standard. So these could all be, two different lists. And, are the interventions that we are practicing, are they evidence based? If not, how are they not evidence based? Like what constitutes, which we would call not evidence based. So when boundaries are ambiguous, implementation becomes inconsistent, just because, everyone is not clear on what we are actually talking about. So different units, different institutions, different stakeholders, they would interpret the same policy in very different ways. And it's not because, they're not being considerate, or they think one thing is more important than the other. It's just that for them, those distinctions were never explicit. So what distinctions does is that it makes everything more tangible, and it makes everything more explicit and easier for people to make the identity other distinctions. So people miss things when they are not, tangible or explicit. And making both sides of the distinction, explicit, clearly naming both what something is and what something is not, would significantly improve clarity and reduce variability in how policies are understood or implemented. So now we are actually, going to come to you guys, where you guys are welcome to, talk or write in chat, where you get to practice this first pattern yourself. You can think about any policy, or, we do not even have to do anything relevant to policy. You can even choose anything that you want. And you can consider a term, probably from your, nursing practice, that stakeholders can, interpret differently. So what is it and what is it not? Some examples that that came into our mind during planning was that, you can talk about discharge readiness, or timely escalation, or collaborative care, anything that you would like to talk about.
So maybe we can also give like a minute, and
Yeah,
then
yeah.
everybody can make a list. So yeah, just everyone, if everyone could think of a term and then make two lists. One would be what is and describe all the ways, like whatever your thing is, and then make another list saying what is not. So for example, as she said in the apple, like an apple is sweet, it's round, it's red. And the is not list would be an apple is not a ball, an apple is not a square, anything like that. So this is just to kind of practice. So we can take a minute and then Arsham can get feedback on it.
And we're also open to, any questions or comments or anything like that, any discussion, because these moves are more about actually practicing. We just did not want to come and just give like a lecture about it. We wanted you guys to, really practice it. So yeah, we're open to any comment, any question, anything you guys would want to share.
Well, I'll start with something. This is Michael. Um, Thinking about homelessness, and we also call it houselessness. So, someone who is determined to be, who is homeless, but see, then there's a difference between house and home. Is it, they have a shelter to live in. If someone has a tent, are they homeless? Maybe not. Just because it may not be what some people might think of as homeless. Maybe that is their shelter of choice. Maybe an RV is a shelter of choice. Is it a shelter? Yes. Is it a home? Well, I guess it could be. So homelessness is not when you have a shelter, right? Does that make sense? You have a shelter. It is when you don't have a shelter. So maybe a person who is living from moment to moment, moving around on the sidewalk with a coat and maybe a blanket or a poncho, that may not be a shelter. So to me, that would be homeless. They're not protected
Yeah.
from the elements. They're not necessarily protected from animals even. So that's how I would think about it. So the reasons for that would be a different issue. So you'd have to talk about that differently. But to identify what, even using those two terms, houselessness versus homelessness, those each have a sort of a context that you think of in your head separately. So you'd almost have to determine. It's like with mental health. Someone decided to call it behavioral health. So someone with psychosis is now a behavior, right? So if you stop being psychotic, then you're not mentally ill, which is great. It doesn't make any sense. So they've changed that term. So identifying the term is very important. And so the difference between houselessness, homelessness, maybe there's something in there that helps you understand the situation just a little bit differently, or a little, so the perspective is a little different.
Yeah, I think that's actually a great example, because if you think about it, the two examples that you gave, one about, mental health and, distinguishing it rather as, what was the exact term? Sorry, behavior?
Yeah, in the United States, they call it behavioral health. Now, to me, behavioral health is
Yeah,
somebody who's skateboarding down the hill and doesn't look to see if there's a car coming. Okay, that's not very
yeah,
healthy. That's a behavior.
yeah,
If you have
exactly.
psychosis or you have severe depression, that's not you may be
Yeah,
exhibiting behaviors, but it's not a result of
exactly.
behavior. So if somebody robs a bank, to me, that's behavioral health. You're not very healthy robbing a bank. you're probably going to get shot. So to me, that
And
it's
just Mhm.
This stems from really some bad silos, in that we have said that some deviations, shall I call it, are developmental delays. And so they're not mental illnesses, they're behavioral illnesses. So if you're on the autism spectrum, or you have learning disabilities, or those kinds of things, those fell under behavioral health. I, like you, find the whole term offensive. And so they opened up all these places and they call them behavioral health. And they expect people who have severe chemical disturbances in their brain to go to a place for behavioral health. And so I agree with you. We have really messed up the terminology for this.
Exactly. So, just by making those distinctions right at what we are calling it, it opens a plethora of questions in terms of, how people would react to it, how it would be perceived. What is the relationship then between, how the patients or the people impacted would actually, utilize it, in terms of, would it be more helpful? Would it not be more helpful? So just making those in distinction just at the label part of it, open so many questions. So imagine if we just like keep making these lists for each and every step, it would open a whole new world of questions and how we can actually change things or look at things. Yeah.
Yeah, and just to add to that, also, yeah, Grace, thanks for sending in your examples on the chat as well. They're great examples. When Arsham and I were also doing our research that we presented at the conference that Michael was talking about, which was on what keeps the working poor poor. The distinctions part was kind of mind-blowing because we were thinking about, how is it that people who are working and are still experiencing poverty while also working, and why is that persistent? But when we were looking at policies that aim to kind of reduce working poverty, we found out that there was no consensus on what the working poor even were. Like, they did not define it. They did not do the exercise of what are the working poor. Who are they? Are they people with specific income thresholds? Are they people with specific kind of working schedules? Are they temporary workers? Are they permanent workers? So this is a very, very big policy problem. And a lot of times, like, these distinctions we think we've made implicitly are the same as other people, but they may not be, because if we're not specifying in policies what something is and what something is not, we are not establishing clarity around that issue.
Yeah. So I'm going to move on to systems now. So systems is basically grouping things into parts and wholes. When what we're trying to understand through this is that any whole can consist of parts, and any part belongs to a larger whole as well. So, and again, these things can exist, should exist at the same time. So, what the move that the Cabreras use is zoom in and zoom out. And basically, the framing that we have used, that is also one of the ways that you can list things down, and it helps structure these moves better. So one, if we start just from X, so it will have different parts, and then X would also be a part of a larger whole. So one, if we look at Apple again, sorry, we're going with the most basic example. This is actually what we started as well with. So Apple has skin, it has seeds, it has a stem, it has a core. But if we zoom out, we can see that it's part of the fruit family, right? Or it could also be a part of, the edible family. It could also be a part of something that's on the trees, that you pick from the trees. So, it could be a part of a lot of different wholes while existing, on its own as well. And if we look more, in the parts that we identified, these parts themselves have parts. So, for example, if we talk about the seeds, it would have a seed coat, it would have an embryo. So we can zoom in, to an infinite level, and the same applies to zooming out as well. So this co-implication, the fact that parts and wholes, they exist simultaneously and they define each other, it's fundamental to systems thinking, because we cannot have a part without a whole and a whole without a part. And if we talk about it in the healthcare context, what we do is that we frequently focus on one scale and we miss out on a lot of other things. So we might be, concentrating on, for example, a staffing ratios, or we might be talking about documentation requirements or discharge protocols or, equipment availability. But these all are parts of something, bigger wholes. They might be, coming together under one whole. They might be part of different wholes. So while these parts matter, they exist within larger wholes that influence their effectiveness. Um, you know, so for example, it can be part of organizational culture, reimbursement structures, regulatory frameworks, workflow design, patient complexity, and then community resources. And conversely, each of these can be zoomed in to reveal their parts. So, for example, staffing ratios, if it's part of, for example, organizational culture or a community resource, it is also has different parts. So, for example, nurse patient ratio, or what is the skill ratio or skill mix? What are the shift patterns? What is the pool availability and more. So, if we start to consciously ask ourselves, what are the parts of this and what whole is this part of? We develop a much more complete understanding of where interventions might be most effective and what unintended consequences might occur. And research shows that this zoom in and zoom out move significantly improves problem solving by helping us see across, different scales. So, yeah, we're going to practice this again. But for example, if we say a team, we have formed a whole. And if we list the roles, for example, nurse, educator, manager, we are identifying these parts. So now you can think of, a whole thing that you can start with, which has different parts, and then what it's a bigger whole of. Yeah, we're gonna give you another moment, and Javeria, feel free to chime in if I missed on something. Education, yes, that could be one part of it, or a whole.
Michael, I see that you put workplace safety from violence into the chat. Walk us through your thinking, how you see that fitting in here in the systems.
Well, as a policy, I'm thinking, what does a hospital designate as a policy to ensure that their staff is safe. So what does that look like? So as a whole, there's a sense of safety so staff can do their job. Now, if you break that down, you think about what does the environment contribute to that? Does the staff education or preparation to interact with people or patients who may be risking, they may be causing disruption, or they may be frustrated. How are they prepared to interact and de-escalate situations? So as you go down, the policy starts branching out on parts. There's a patient is part of that. How do they know how to behave when they're frustrated? How do staff know how to behave when patients are there frustrated? What do managers do to ensure the environment? What does the overall environment of the hospital, led by the CEO, what does that look like? So the whole would be a sense of safety for everybody. So you would break that all down if you were thinking about how do you create a policy that addresses that sense of safety. Does that make sense? Does that fit in this?
Yep, definitely. It does make sense. We can also look at it how you have identified, different stakeholders of that whole environment, and who would actually be contributors to the workplace safety from violence. And when we're talking about workplace, we might limit it just to, for example, managers or administrators or doctors or nurses. But you also talked about patients, of how they also interact within that same environment, and how the people who work at the hospital could be impacted by them as well. So yeah, that's a good example. Javeria, would you like to add anything?
Yeah, I would just like to add that I think I particularly value this kind of like zoom in and zoom out, because I feel like when we're making policies, we're just doing either a lot of zoom in or a lot of zoom out, but we're not barely doing both at the same time. And that is why, a lot of the policies that we see today, they either like inadvertently impact something else that was not intentional, or because they didn't really go into all the specific components of by zooming in, they're not effective. So I think this is like a very valuable kind of exercise to do when we're thinking about policy or any kind of problem, because it really helps us think in two different scales.
Yeah, specifically, I was at a hospital where every year they survey staff and they ask them what they really want. And the nurses said one time, "We want to stop getting strangled." So the executive team said, "Oh, you need to learn resilience." So they hired a consultant from a university to come in and talk to everybody about how they can develop resilience. And they even required everybody to install an app on their phone, and it was called 3 Good Things. They said, if you say 3 good things over the course of a day for 2 weeks, you will feel better about things. So the executive staff, their perspective was so far zoomed out, they were probably functioning without oxygen at all. They had no intent. So you look at the zoom in, zoom out. Oftentimes the policy at the top level, which is what happens, is definitely not consulting authentically, realistically, or truthfully with the folks at the front line.
Yeah, and we'll talk more about this further down the presentation as well. But uh, this is also where we are actually looking at, just handling symptoms of one of the issues, and not actually, what the foundational problems is. So, yeah, and then what you talked about, how people who are actually making those policies or implementing, different things are not the ones who have had any experience in the real time. So they are making that policy in a faraway place, just in another room, without having any, idea of what's actually happening or what the ground realities are. Yeah.
And that goes to
Um,
perspective.
exactly. Yes. Yeah, I just want to talk quickly about Grace's example, where she said that, the bigger whole would be care planning, then patient discharge, and then there would be different parts, which is, education, prescription, follow-up appointments, home care, medical equipment, etc., which is a great example. And if we look at it further, so for example, the bigger hole she talked about is care planning, right? But there could also be other bigger holes which encompasses patient discharge as their parts. So, for example, it could be, the hospital quality and safety programs, or, readmission prevention initiatives, or, value-based reimbursement models. So it's just interesting to see how one thing can actually be part of different wholes as well, while existing as an individual thing as a part of those different wholes, and then how those wholes are actually connected with each other as well. Yeah. So now
Yeah, Arsham,
let's.
can I just add one more thing? By the way, if you all have any questions about how to make distinctions or how to zoom in and zoom out, just feel free to kind of ask as we go, because it'll really help kind of bring it all together at the end later if you're building like smaller understandings of each of the patterns. And also, we understand that it might be a lot to kind of figure out in real time for everyone. So, asking questions would really help kind of make this session more productive.
Yeah. So now the third pattern is relationships, which is basically to understand how things are connected, how they influence each other, and how they depend upon each other. So every relationship, it consists of what we call action and reaction, but these aren't necessarily sequential, or they're not necessarily cause and effect, in a linear sense. Relationships can be in unidirectional, they could also be in bidirectional, they could also involve feedback loops where each influences the other. So the relationship, for example, we have given two different examples. The first one, if we talk about, it actually captures a relationship between policy design and clinical practice, and then the relationship between clinical practice and patient outcomes. And there's also a relationship between, nurses and patients. So the first one is where you can look at things in a much more broader way. And then if you want to delve deeper into, for example, the two individual relationships, uh, then the one on the right side is what we would actually, for example, look at. So, for example, if from the clinical practice we take nurses, and then from the patient outcome and experiences we're using patients, and we see what is the relationship between them. So in between we have actually named the relationship, which is care response relationship, and you would also see that there are arrows which are, going from nurses to the patients. So for example, if we can also change it, in the other direction, or we could also add other things. For example, healthcare system in between, and then it would be, the arrows would be going both ways, because then the patients are a part of the healthcare system, and nurses are also a part of healthcare system, and they have like a bi-directional, relationship with each other. So once we have established what the relationship is, we then zoom in, the part whole practice that we did before, where we zoom into the relationship. So between the nurses and the patients, where they're having a care response relationship, we have things like, information sharing and diagnosis. And Javeria, can you read the third part? My screen is being covered. That's okay, it's fine. It's just one other part of it. I just didn't want to mispronounce it, but my taskbar below is
Yeah,
kind of
it's
covering it, so I
emotional
cannot make
support.
mistake.
Yeah, it's
Oh yeah,
emotional support, I
yeah.
think.
So emotional support. When we talk about, complex systems like healthcare, we need to understand that feedback loops are particularly important. So, for example, if we take the example of, documentation requirements, so increased documentation requirements, don't flow in just one direction. They would be, for example, affecting nursing time, while affecting the patient interaction quality, which influences patient outcomes, which impacts satisfaction scores, which then affects the hospital reimbursement, which then influences staffing decisions, which circles back to affecting the nursing, workload. So these feedback loops, where the output of a process influences its own inputs. When policies fail to account for these, relational dynamics, particularly feedback loops, they often produce unintended consequences. So policy optimizing one relationship may inadvertently, disrupt others that weren't considered in the design process. So, um, let's talk about, forming these relationships, of how you see it and how you understand it. So we need to see how they affect each other. What is the relationship between them? And for example, consider both the nature of the relationship and also the direction that the impact is going in.
Ashim, should we break that down? Um,
Yeah.
should we just do first like two things and then identifying what the relationship is, and then we can do the zoom in? It might
Yeah,
be
we
too
can do
complicated.
the first move first. Yeah.
Okay, so could you just explain that again so that we're clear?
Yeah, so basically, in the first move where we have said X, Y, and Z, we are just identifying things that are interrelated or interconnected to each other, and we are not naming those relationships right now. So for example, if we say uh, doctors could have a relationship with nurses and with patients both. So could be, the emergency service, providers, in terms of like the EME workers, or the firefighters who even come to the hospital or anything like that. Or if we are talking about, um let's talk about like staffing levels. So that staffing levels and the documentation could be one part of it, and discharge policies could also be interconnected, all three of them, like they all are interconnected and they have a relationship with each other. It depends on, what you're trying to find out. So that is why you're looking at specific things and how they are interconnected or how they're impacting. Javeria would like to add something.
Yeah, just to add, I think like basically kind of the intentional naming of the relationship really makes explicit how both of these things are being, how both of the things are being affected and what the direction of the impact is. So, it becomes really important to actually sit down and instead of kind of ambiguously knowing that, well, this is related to this and this is related to that, kind of doing the exercise when we're analyzing policies and how exactly they're related and identifying that relationship really helps us build better policies then as well. So this is also a really important move.
So I could see in a hospital, if someone goes to the emergency room with, let's say, a psychiatric condition, they have severe suicidality, and they're released. They determine that they're okay and they can go home. So X could be the treatment team at the hospital. They've assessed them and evaluated that person. They've said you're good to go, and we've set you up with an appointment. So Y could be the patient, and they leave the hospital, and Z could be the follow-up appointment with some follow-up therapist. Well, what happens a lot of times with this triad is that there's a fourth part that must take place. For example, how about the family? If the family's not notified of this, oftentimes the patient is not able to make good decisions because the part of them that's sick is their decision making. And so it's not just there are relationships and how effective those relationships are, but what is the bare minimum of that system? That's important too. So if the emergency room gives a person a piece of paper saying we've treated you and now make sure to follow up with your caregiver, and they don't follow up with the caregiver, that relationship is broken. And if the patient doesn't follow up with the caregiver, that relationship is broken too. So if they had brought in maybe family members, that could be the connection to enable that relationship of the whole system.
Well, and in a perfect world, there would be a case manager who would be notified, who could then coordinate back to what Eleanor was saying, social work and housing and any number of other resources.
Wouldn't that be nice?
And then, of course, the
right
hospital's evaluated on what the patient's outcome is.
Yeah, within a couple of days. After that, they don't count it.
And like for example, sorry, so go ahead.
No, you go ahead and then I'll say it.
Yeah, I'm just like, it's interesting because just right now we identified a relationship and then we were like, well, now that we know what the breakdown is in the relationship, then the case manager would help build this relationship. So automatically, if we're making some kind of policy, in that policy, then there would be, the policy would include that there needs to be a case manager for, this patient. And that is the value of kind of doing, explicitly naming the relationships and how they may be impacting one another when we're trying to build a policy that's actually effective.
And then the other part of that is to determine capacity. I knew a social worker with a VA who had 4,500 clients.
4,500 is a lot.
Yeah.
Yeah.
She wasn't real excited about her job.
Yeah.
So then there's capacity in there too. How do you, but that's at a different level, of course.
Yeah, definitely. And just coming back to what we were talking about earlier of how you distinguish. So for example, there's need to be a caseworker and the family needs to be notified. You both, Michael and Eleanor, are also practicing the is and is not list because you identified what was not written explicitly in the relationship and you diagnosed that, this is the part which is missing, but it needs to be an essential part of it. So when we look at, for example, how you said, that we're just looking at patients and, the doctor and the discharge of how that's happening, what we are forgetting is that, what's actually going to happen once they are discharged, who's going to take care of them, are they going to follow through? And that is where the is not list, you brought that forward, which shows how critical that information is to actually making a policy or a process that would actually, benefit everyone. Because then that would also reduce the healthcare, load if they're not, readmitted and if they're actually, going and getting themselves checked. So yeah. And I think we also kind of touched a little bit, we zoomed into R as well. So, for example, Michael, if you would want to follow through on the same example that you gave. So, if we take X as doctors or nurses and we take Y as the, the family of the patient, and we could maybe you would want to distinguish the relationship and then zoom into what the relationship would look like for a good policy. Okay, maybe Michael's not there.
Oh, I'm sorry, I misunderstood. No, you said to zoom in on those, or what were you suggesting?
Yeah, my question was that, we did the X, Y, and Z thing, like the first move. And if we want to zoom in, so for example, for in X, we take that as, the doctors or the nurses, and Y we take as the patient's family. And then if you could distinguish the relationship between them and then
Hmm.
zoom into that
Yeah,
relationship,
so
what that would look like.
yeah, that would look like maybe a barrier would be they can't get in touch with family. Maybe they're
Mm-hmm.
estranged. Maybe there is no family that they know of.
Yeah.
So you would have to look at some other thing. Maybe the way that they relate is through an app. Well, does the patient have a
Mm-hmm.
phone that's charged? I know one hospital system that we've used. They have an app, so when you after you're discharged every week, they send you a message saying, please fill out the survey. Well, there's no place in the survey for comments. It's only checklists. So it's an inauthentic way to relate to other people because you can't really ask a question. You could only ask. So the quality of that communication is part
Mm-hmm.
of you can measure how effective that is by the quality of the relationship. So yeah, you could zoom into how they relate to one another. Well, the person at the hospital could say, well, I left 2 messages. I can't do any more than that.
Yeah.
I got 25 other
Yeah.
patients. So there could be, so thank God AI is waking up and pretty soon we'll all be cared for by carrying robots.
Yep. Yep. That's an interesting way of, yeah, zooming in, because we're not just going as part whole, but you're identifying, different ways that could become part of relaying that important information. And what could be, different ways of doing that that can also be categorized as zooming in and, parts of the whole. So, Ray, would you like to add something before I move on?
No, but I am curious as to how no one has any questions because when I was learning this, I had so many questions. So I just hope everyone is comfortable asking questions if they're confused. But yeah.
Yeah.
I think this is
Okay.
very helpful. Good exercise.
Okay.
Yeah, this is very
Um,
practical because it makes us think about how we think. And the idea behind our community is to change the way that people think about what to do. A lot of people say, well, I want to do something, but I don't know what it is. Well, first of all, you got to
yeah.
think about what it is that you're doing. That's the first thing. And
Yeah.
that's the hardest thing, to organize your thoughts. So what you're giving us is a way to think that's concrete, that's applicable, and that you could utilize in generalize in different situations, which is why I love this. It's difficult because it's different. And that's why I
I
love the Cabreras, because they're saying we're going to teach people how to think because we're not thinking very good. That's basically what they say on every.
I have a question. I mean, I wanted to wait till the end. It's a little I'm like iffy, not clear. It's from the distinction, but I didn't want to disrupt, but I'm still like it's kind of, you know, keeping me
Yeah,
sort of
sure, go ahead.
preoccupied. So, when we're talking about distinction, how do we make sure that in doing so we are not being redundant? How do we make that clear when we are trying to say, okay, what is this and what it is not, if I'm getting it
Mm-hmm.
correct? How
Yeah,
are we making it clear that what we are looking at here is not being redundant when we are thinking about what something is not? So that it
yeah.
doesn't seem like this is a waste of time. I hope I'm making sense in what I'm.
No, that you are actually making a lot of sense, and you have actually brought me back to this one day when we actually started talking about it, and our professors, the Cabreras, they talked about how what is a sandwich and what is not, right? So we wrote two breads and maybe a burger patty in between. That's a sandwich, or mayonnaise or anything. That's a sandwich. But then after the class, me and Javeria started thinking. So for example, if it's like two things and then one thing in between, if that is what is a sandwich. So for example, if we hug each other and my arms are around Javeria and Javeria is in the middle, is that a sandwich as well? So there is definitely redundance in it as well. especially when you start thinking of it at first, because you are experiencing or you're trying to exercise a very new kind of way of thinking, something that we have
Mm-hmm.
not done before. So at first, the lists could be, non-exhaustive. They could be like really long, they could be really short. Sometimes nothing's coming to your mind. You think it's not relevant. So you're just like, so for example, calling an apple it's not a ball, one would think it's very obvious, right? But that's
Right.
just for practice. But then when you sit in, start thinking of things in context, I think then probably the things would start becoming less redundant, and you can just focus on the context and things that are just relevant, you think, to the context. But even then, that is why it's important to have non-exhaustive or like really long lists, because sometimes we think that it's not, relevant to the context, but it is. I know this is like an explanation without an example, but I hope that helps. Javeria, if you want to add anything, please do.
Yeah, no, I think that was a great answer. Thanks, Arsham. It's true. I think even when we started doing it, we were like, we can make these is and is not lists forever. Like, where do we stop, right? And you're so right in thinking that as well. I think, like, for example, if I think of if I give an example of what Arsham is saying, that when you have a context to how you're thinking, it automatically just situates your like is and is not list, which means that then it reduces redundancy. So, for example, if we think about who are the working poor, right? So, what is a person who can be categorized as working poor, right? Then we could, I mean, I could say that a working poor is not an alien, and it's someone from Earth. Like that could be one thing, right? But then that would be too far off. So when
Right.
I'm thinking for a policy question, if I'm thinking what is a working poor, then automatically, because I'm thinking in a context of reducing working poverty, I'm going to be like, okay, what are the income thresholds? What are they temporary workers? Are they permanent workers? Do they have full-time jobs, or am I also including part-time workers? So, that's the thing. But right now, for practice, um, which is very important in this kind of like analysis, like DSRP analysis. For practice, we could even kind of be kind of do things that may feel redundant or too extra, because as Arsham said, they really help open up that world which often we don't see. So, but automatically, after we are in practice of kind of always identifying the other when we're thinking of identity, then when we're thinking about it in a situation, then it kind of just we end up limiting the context and reducing redundancy. Does that answer your question?
Yes, it helped. Yeah, thank you so much. Yes, it did. Thank you. I didn't mean to regress.
No, this is great. It gave us confidence that what we are saying is actually making sense. Yeah, so now we're going to talk about perspectives, which is basically our fourth pattern and the last one. So, perspectives is basically recognizing that any issue, it can be viewed from different vantage points, and what we see depends significantly on where we are looking from. So, perspective consists of two co-implicated elements. One is the point, and the other is the view. So the point is who or what is viewing, and the view is like what is seen from that particular position. You cannot have a view without a point from which you are viewing, and you cannot have a point without some view from that point. So basically, re-emphasizing on the co-implication part, that both of them would be existing at the same time. So the example here that we have used is that a new documentation requirement is introduced in a healthcare setting. It could be, any documentation, and that is basically our view. And apologies for that. And then we have three different perspectives on it. One is the perspective of nurses, which could be that more documentation could mean less time with patients, or, unpaid overtime work. But that is just one of their perspective. It could also they could also have other perspectives as well, that okay, this increases accountability, or other. So one uh, point can also have different perspectives, but this is just one of the examples that we're using. The patients could think that more documentation may improve safety and continuity of care, and the policy makers, they might think that documentation creates data to measure quality and outcomes. So now when we look at these perspectives, we see what each of these three different categories are looking at and what are their expectations. But as Javeria talked right in the beginning, that our mental model and the reality, they need to be as close as possible, because if not, then that is where the problem occurs. So the policymakers just probably looked at it that documentation would help them measure quality and outcomes. They probably did not think about the other issues that it could create. So, for example, for nurses, if they're already working overtime, if they're like staff shortages, and they still have to do all of these more documentation work, then this would mean less time with the patients, or this could lead to burnout. But this is something that maybe the policymakers did not take in account while introducing this policy. Or, for example, with the patients, when they're thinking that, if there's more documentation, it will improve safety and continuity of care automatically. So there's an expectation now, but because the staff is so, overworked, that might actually not fall through and actually, create other issues, which could then result that the patient expectations were not fulfilled. So it is important to understand who is looking at what are they thinking, where are they coming from, and so this basically what it would do is that it would increase or improve our ability to understand stakeholder experiences and anticipate implementation challenges. And this is why it is important that we include different perspectives in policy making, because if someone is making it just without any on ground or real time experience, without knowing the realities, then there's a gap between the policy and the implementation process. And maybe even the if the thought behind the policy was great, but it's not actually resulting into what the intention was. That is where perspectives come in, and why it's important to kind of look at it through different perspectives.
Arsham, this is Nina. I'm looking at this, and it's you've simplified the situation with this table, but let me
Yeah,
complexify it. In terms of
yeah.
shared value and collaboration, more
Mm-hmm,
documentation, less time with patients or overtime work. That's also a
mm-hmm,
patient perspective. I'm pushing this call button and this nurse isn't coming, and all they seem to do is sit there and document. That could be a patient perspective. Same
mm-hmm.
thing, more documentation may improve safety and continuity of care. That might be a nurse perspective, because the nurse might say, great, now as the case manager, I have access to so much more information. You could substitute nurse there. And then documentation creates data to measure quality and outcomes. I, as a nurse, might say, I feel like I work hard, and I'm not just a part of the hotel cost here, and I need to justify my existence. And I can do that with the data and the quality measures and the outcomes. And so, honestly, if we were sitting at a table, these could be shared perspectives.
That is actually a great example, and that is why me and Javeria started with the Apple examples, because we are not really experts on, uh, the healthcare perspectives and the nitty-gritties of it. But yes, you're actually absolutely correct, because these could be shared perspectives. If you're looking at in just one smaller context, maybe the nurses might be thinking this, or the patients might be thinking what we have written. But you're right, these could be shared as well. And as I said, that the same, like all three of them could also be having different perspectives at the same time. So yeah, all of them could be existing at the same simultaneous point, which is also a technical part of, systems thinking that we did not really include. But you're absolutely correct. Javeria, would you like to add anything?
I think that's a great example. Thanks so much for that. And when we also look at policies that haven't worked, what we often do find is that actually lived experience and people who, for example, just to go back to the working poverty example, right? People who experience working poverty, their view was not included in policies that aim to, reduce working poverty. So just in the same way, frontline workers, their views may often not be included when developing healthcare policy, and which is why it's kind of really important to do this exercise where you kind of like think about an issue and then map out the different points through which that issue can be viewed, and then see what perspectives exist, and if all perspectives are then being valued and included when developing policy. And for example, if I talk about the working poverty problem, when we looked into like whose perspectives were included in policies around that, there were either like economists or policymakers, and none of them were like immigrants or and people who were actually experiencing like had a lived experience of the problem. So that's why also it's very important to do this kind of exercise intentionally.
I think
Yeah.
also the way that we're approaching problems and the term wicked problems is very important because social problems are not simplistic. Unfortunately, policymakers, and I've seen this in the hospital more than once, they want to reduce everything to the minimum amount of answers. So they get a fishbone, and we have talked about fishbones because it's an inadequate model for a complex system that's adaptive, that's constantly changing. And so this approach is DSRP. When you get to this point of perspective, it's expansive. It's not reductive. And in the past, managers and thinkers want to reduce everything to the smallest part. Okay, that's a piece, but that's an incomplete piece because zooming out is where you get the Easter eggs and the black swans and I didn't know that. I didn't even think aspirin would be good for a certain thing because I hadn't thought about it. So, I know that you're bringing about this in a simple format, but the practicality of this is not simple. It's very expansive.
I think
Yeah,
for
so
me,
basically,
I'm sorry. I just
no,
wanted to
go ahead,
piggyback
Sandra.
onto Michael.
Yeah.
I think I really like this in terms of what we are about in this group, how to really get nurses involved in policy. And it reinforces the voice of everybody who is concerned with whatever it is that we're trying to change with policy. And I think it for nurses, if we have something like this that really emphasizes the importance of our voice here at this table, right? And showing in a nice glaring way everybody's voice coming in, and so we can see how collectively and overall in what we're trying to improve with whatever that policy is, we can see that outcome that we want, and reinforcing our voice and the importance of that nursing voice there. I like this
Yep.
because it really reinforces that for me.
Yeah, and just the
So-
fact that you're talking about system thinking, I mean, that sounds like something difficult to grasp, and yet you're breaking it down a little bit so that we could actually use it to solve problems that we encounter all the time.
Yeah, yes. So, all of you are absolutely correct. We have really simplified it. It's not as simple as that. And even when we worked on the working poverty, because that is just one of the few things that we worked fully on it, the final total map that was created was really extensive and really huge, with different different moves interacting with different moves in in a very different manner, and then having these multiple perspectives as well. I think it was Nina who talked about how these could be shared perspectives. So coming back to that, she was absolutely 100% correct that these could be shared perspectives. Um, it's also important to understand that when we practice this move, what it also allows us to do is that understand the perspective of the other person and giving them that time and space that maybe the other person is just looking at things differently. Maybe it's not a bias or something that they're against. That could also be there. I'm not saying that that couldn't be there, but sometimes just that they do not really understand that our perspective is different and it's important in its own way. And because, as Michael said, it's these are wicked problems, two perspectives which are very different could also be correct at the same time for different people, because it might be on a different priority list. And that is why it is important to document all of them and then see what makes the most sense, or what consensus could be formed between all the stakeholders. Yeah. So
Yeah, and just,
now,
all right, so just to
yeah.
extend that, if you could go back once on the slide you just were in. Yeah, so for example, like if we were actually doing this exercise of actually like writing down the views that different people might have on the on the same policy. For example, if policymakers were perhaps thinking beyond just that, oh, if we have documentation, that's going to create data for us and we're going to be able to use that data, so let's increase the documentation. If while they were making some kind of policy on that, and they were also thinking about or considering how the nurses may view a new documentation, which would be that overtime work or extra work, then while making the policy on new documentation, they would also perhaps realize that they need to increase staffing or they need to reorganize the way nurses do their work, right? And then what that means is that when you make such a policy, it's almost like in the reality of the problem at the hospital in real time, then that policy is just it matches well, it has like a better structural alignment, you know. So it's really important. Like for example, when we were researching about working poverty, it was insane to us that no one who was actually experiencing working poverty had been included in the conversation, you know. And it was crazy to think, and but that is unfortunately how policy works, that it is completely normal to just not take the perspective of the most critical people who are involved, and by doing this exercise we kind of reject that normal practice. We acknowledge that for one thing there are multiple people who are viewing it and they must be included and recognized. And I think that's really that has a lot of transformational potential.
Yeah. So, carrying forward what Javeria said, if we do not include all the perspectives, or at least the most important ones, what we're doing is that we're creating blind spots. And those blind spots are the reasons why a lot of policies actually fail. So, what we see depends on where we are looking from, and the same issues can appear very different when seen through another perspective. So, we might actually be, I think we have like 20 more minutes to the 120 minutes final, uh, time as well. So, Michael, please let us know if you're doing okay on time. But this we have talked a lot about this. Would you guys like to do another example, or can we move forward?
I think we catch on to this. I think it makes sense. We talked about it that last slide, I think.
Yeah. Okay. So basically, that was what the four moves were about. And now this is also something that we have been talking about, throughout our slides as well. But l- let's just talk about why this conversation matters, or, why systems thinking and specifically the DSRP framework is particularly relevant for nursing policy work. So policies, they are frequently designed in settings removed from day to day clinical practice, often by people who may not directly have experienced the policy's effects on frontline staff, on patients, on communities. So this is a structural reality of how policy processes work, but it creates a gap. And there's often like a significant disconnect between what a policy intended to achieve on paper and then what it actually, produces in practice. And this disconnect persists because policy problems aren't simple. They have, interconnected issues. They also have multiple actors. So, for example, public, private, community sectors, each would have a different level of influence. They would have different priorities. They would have different constraints. Then, as we talked about, the diverse perspectives on fundamental questions. So, what actually is the problem we are trying to solve? What would success look like for different people? And then also, who gets to define what success would be? So, these approaches, would they be feasible given the constraints? So these are all, very practical questions that we were talking about. And then lastly, uncertainty about, how any single action will create ripples through the system. So without, feedback loops, how can we, amplify the intended effects? As Michael said, that, policymakers try to like really simplify things, which is actually not true in reality. So we really need to see that, what emergent properties might arise that we can't predict from understanding individual components. And that is why we need to see them as more adaptive systems, as agents which have their own, agency, which they have their own relationships, which have their own feedback loops throughout the whole bigger system. And this is also something that we have talked previously as well. So I'm just going to quickly, go over it, that we mostly solve symptoms. We do not really create structures. We do not include perspectives or feedback from the frontline professionals or people who the policy is directly impacting. And sometimes you're trying to, optimize one outcome, but what it does is that it creates other plethora of, harmful things or other problems that then need to be sorted out because the policy that was introduced wasn't comprehensive enough, or it was made in a silo or in an isolation. And we need to, treat people as we treat people as variables instead of like participants who are actually being impacted. So there's also, a play of empathy here. So what systems thinking does is that it can help policymakers anticipate these failures earlier, or just try to navigate through the system in a way which would be, more inclusive of different perspectives and then systems, and just making distinctions which would be important to the policy that they're trying to frame. This is just a summary of what we have talked about. What is the difference between linear thinking and systems thinking? We do not focus on individual parts. In systems thinking, we look at parts and wholes. We are more flexible. We would be looking at changing groups, how they interact with each other, how we are not going to rigidly categorize or create hierarchies, how we have also distinguished that in different examples, especially the perspective and how it could be shared perspectives. And then we recognize that everything is not a simple cause and effect. It could actually be complex interconnected causes. One thing could be causing an effect, and the effect could be creating a feedback loop, and causing that cause as well, or an effect could have, multiple other causes. Um, and then we see systems as evolving and adaptive. They are not fixed, they are not dead structures. They have the capacity to evolve and, interact with whatever is given or provided to them in the environment. And lastly, we cannot frame choices as either and or. We need to allow multiple options and trade offs. So this is what we wanted to leave you guys with, which was that you can think of a policy or a rule that frustrates you and just think about, what problem was it trying to solve? What connections might the policymakers have missed, and who wasn't in the room when it was designed? So basically applying the distinctions, systems, relationships, and perspectives, all the moves that we have talked about on it. Yep. So that was our presentation. We're open to discussion or any questions that you guys have. And we also understand that this was a lot to take in just like in an hour and a half. We actually spent a year on it. So we are open if you guys have any questions even after the presentation. You guys can reach out to us on our email. And even other than that, the Cabreras have their own podcasts on systems thinking. They also have their website. So there's like a lot of resources that they have shared for everyone to see. Yep, that's it from our side. Javeria, if you would want to add anything.
Yeah, I would just like to conclude by saying that basically, which was a great, this is something that we also learned during our training, and I thought it was a great way to kind of summarize what systems thinking did. And that was that oftentimes, like, if there is, let's say, like, there is a leak, right? Oftentimes if there is a leak from and water is coming out, if there are like 5 holes and we just kind of uh, put our finger in one hole, and then we're like, well, we put our finger in this one hole and then water is still leaking, so I guess we this is probably really hard to solve, so let's just stop trying to solve it, right? Which is often what happens in working poverty complicated issues like working poverty or healthcare or like gender violence or anything. We just silo one kind of solution. We say that, okay, for now we will implement this one policy to solve gender violence, right? And then when that one policy doesn't work, we're like, well, I guess violence is really hard to solve, and then we'll kind of continue doing it, but we never really look into it too much. But what systems thinking like forces us to acknowledge is that there are actually like 5 holes, and you need to put all your fingers in all the 5 holes at the same time to stop the leakage. And it's important to understand the complexity of the leakage. You can't just simplify it to be like, we'll just put it in one hole and the water should stop. And if it's not stopping, well, we don't understand what to do. So, kind of systems thinking really forces us to think about where in a policy issue, where are the different like leakages, how are they interconnected, and what must be done together, in coherence to solve that issue, instead of thinking about it in isolated parts. And that's why systems thinking can be really a useful tool in both personal and professional lives.
Yeah, and just adding a last thing to what Javeria said, another, like a broader way of looking at things, especially policies through the lens of systems thinking, is this one phrase that we learned, which is possible, which means the purpose of a system is what it does, not what it intends or not what it started with, but what results it actually produces. If it's not producing the results that we wanted to, then that system is not working. And many times that system is not working because we are like looking at it in a very siloed approach. We need to keep working on that system and then all the other systems that are interconnected and try to like solve all of them together. Like we need to stop the all 5 holes from leaking together, and that is when the leakage is going to stop. Yep.
I think this has been really helpful. I think it gives us really great perspective. It's exactly what we try to do here in the cafe by changing the way that we think about the same thing to either keep pushing if it's working, like you mentioned, or to totally shift and change based off of new information that we learn, a new perspective that we have. And I like that you bring up silos because I think we see problems, nurses see problems firsthand at the system, they're the symptom level of why healthcare policies fail. But it's when we start to think outside of our clinical walls, outside of traditional practice areas, and engage more, not only with other healthcare disciplines, but with other professionals too, to address, the root cause of issues. We can bring that perspective, but really to address the full policy change, we need to understand their perspectives to be able to even communicate and collaborate and to understand all of the different, parts that kind of go into it. Because just at the very basic example, health hospitals are not just health delivery systems, but they're also businesses that have to operate, whether it's for profit or not, to be able to sustain. So that it's a really good way to, it's a good framework and practice for us to be able to change our thinking to be better collaborators. So thank you. And I also just want to acknowledge, Arsham, I think it's very late for you on a Saturday night. So thank you so much for being here and being so engaging as well.
Oh, it was my pleasure. Thank you for having me here. I learned a lot actually. Me and Javeria, we were really scared because we were like, we're talking to, healthcare professionals and experts, and how do we, not come off as people who do not really know anything about that. So yeah, I think we actually learned a lot as well.
Well, that's one thing we talk about here. People don't realize when you say healthcare, virtually every policy is related to our health, whether it's
Yep.
clean water or whether it's seat belts or whether it's domestic violence or human trafficking. Every single thing is about our health. I can't think of a single policy. Even when a spaceship goes off, they have to get permission that there's no planes flying in the air, so the rocket doesn't hit the
Yep.
plane. I mean, virtually every policy you think about is related to health. And so
Yep.
when I talk to people about healthcare policies, they say, well, I don't really want to get every single thing. It relates to us as individuals, and I would love to see more people as individual
Mhm.
volunteers jump into the fray, because bureaucracy runs policy. And my experience
Yep.
with community at the community level is there are community county workers that change roles every 2 years. So then you have another person in here, and programs are designed to be driven by a person. That's just how they're driven. When that person goes away, so does the program, or it takes on a different perspective. So I think, more volunteerism, where people become engaged in what's happening in your community, that's where healthcare changes. It's not at the national level. Yeah, we don't have much of a voice, but we have a very strong voice. And then if we're prepared, if we come into the room and we have a voice that's not only different, but it's reasonable and gets to the problem that helps us to the real solution rather than a solution of the most popular ones, we're going to be seen as having value. And I think that's the most important part of what we're trying to do, is help people become valued in their community. So your healthcare, whatever policy you make, is chances are it's related to healthcare, no matter what your background is.
And that's a new perspective and a whole and a part that I learned. I never saw it that way.
Well, I do have questions for you that I want to follow up with. I have some questions about how to think about what we're doing, and maybe later in the future we can have a conversation about how you can help guide what we're doing through the lens of DSRP, and maybe help us in our project. So if you run into anybody that's interested in policy and learning about it, aim to our website. It doesn't matter if they're a nurse or not. Everybody's interested in health.
Definitely.